Good afternoon, everybody. I'm Dr. Pratik Tambe, Chairperson for the AMOG's Endocrinology Committee. A warm welcome to today's event. Today's theme is Key Issues in Obstetrics and Gynecology, and we have three eminent faculty from all over the country who are going to speak to us on three very important issues in day-to-day practice. But before we begin today's scientific proceedings, I would like to place on record my gratitude to the AMOG's office bearers. First and foremost, our esteemed President, Dr. Nandita Palchetkar. Madam is the current President of AMOG's. She has also served as the President of FOXI, Mumbai Society and IG in the past. Currently, she is the Vice President of ISAR. And we'd like to thank Madam for all her support, guidance and blessings over the years. Today is a very special day for her because today she is being awarded the Fellowship of the Royal College of OB/GYN and she's in London. The ceremony is to take place shortly. And we would like to congratulate her on receiving the FRCOG today. Thank you so much, ma'am, for always being there for us. Next slide, please. I'd also like to place on record my gratitude to Dr. Arun Nayak. Sir is the Secretary of AMOG's. He's also served as President of the Mumbai Society in the past, a fantastic vaginal surgeon and a legendary teacher in his own right. Thank you, sir, for your blessings for all our academic endeavors. Next slide, please. At this point, I'd like to express my gratitude to the ICOG office bearers, the chairperson of ICOG, Dr. Uday Thanawala, the secretary of ICOG, Dr. Ashok Kumar. Thank you for the ICOG credit points for the entire series that we have done, including today's program, which is accredited with one ICOG credit point. Next slide, please. We have three fantastic chairpersons today. The first and foremost is none other than Dr. Sagar Kataria. Sir is the zonal coordinator for the AMOG's Zone 2. He's a senior consultant in OB/GYN from the Kamala Hospital in Satara with 25 years of practice. He served as a past president and a secretary of the Satara OB/GYN Society. He's a PG teacher at the district hospital in Satara, honorary consultant at Aranglia Hospital in Satara, and he is known as the organizing chairperson for the AMOG's 2019 conference, which was held in Mahabaleshwar. Sir is a very active person, and amongst his extracurricular activities, as you can see, he keeps fit by practicing badminton, running and cycling. Thank you so much, sir, for being here with us today. Next slide, please. We also have with us Dr. Sashmita Das. She's a gold medalist and she's a past president of the Karimnagar OB/GYN Society. She is also the vice president of the IMA Telangana, and she is a president of an NGO called Sai Seva Samiti. She has 66 original scientific paper presentations in national and international conferences, which is something which is very much commendable considering that she comes from a very small place in the interiors of India. She's also been awarded by IPE for excelling in career growth. She's a national level player in athletics. She has two daughters, both of whom are doctors, and we regularly see them on Facebook. And thank you, ma'am, for gracing the occasion today. It's lovely to have you with us as one of the chairpersons. Next slide, please. We are also privileged to have with us Dr. Latika Agarwal. Madam is currently the secretary of UP ISAR. She has been a gold medalist during graduation as well as post-graduation in OB/GYN. She has to her credit several different publications in various reputed journals. She has been a member of the UP State Council for Medicine as well. Successfully delivered several lectures and presented various papers in national as well as international conferences. She's been scientific chairperson for UPCOG for 2 tenures, awarded by the Governor of Uttarakhand for exemplary contribution in her field. Awarded as Woman of the Year by Bareilly authorities in 2016 and again in 2017. And we really look forward to seeing her and hearing from her to the rest of the scientific proceedings. We have 3 eminent national faculty who are going to be speaking to us. The first of these is Dr. Bhagyalakshmi Nayak, a very dear friend and a chair for the FOXI Oncology Committee. Next will be Dr. Rekha Thote. She is the secretary of the Thane OB/GYN Society. She's my gawali, so to speak. And lastly, we have with us Dr. Rakhi Singh, who will be joining us a little later. She's the one who took over as the chairperson for the FOXI Endocrinology Committee when I completed my tenure. So without further ado and wasting too much time, I would like to hand over to the chairpersons And I would request our chairperson, Dr. Sagar Kataria, sir, to introduce the first speaker of the day, Dr. Bhagyalakshmi Nayak. Over to you, sir.
Good afternoon, everyone. At the outset, I would like to express my gratitude to our President, Dr. Nandita Palchetkar, Secretary Dr. Arun Nayak. Big thank to Dr. Pratik Tambe for involving me for this webinar. We are having a fantastic webinar today, and at the initiation, we'll have a talk from none other than Dr. Bhagyalakshmi Nayak. Madam is chairperson of Oncology Committee of Foxy. She is associate professor at Department of
just a correction, I was
GYN Oncology at Qatar. She has been vice president of GYN and joint secretary of AGOI, and she is executive member of ISCCP. She has delivered many orations, and she has been writing a lot, and she is assistant editor of IJOG of Oncology. Madam, the screen is yours.
Thank you so much again for all those kind words, and I really thankful Dr. Pratik and all the executive members of AMOGS for giving me this opportunity. And I think I have been a regular speaker in most of the AMOGS meetings. So thank you again for the opportunity. So in the meanwhile, let me just share my screen, sir. Yes. Yes, I think I'm visible and audible too.
Yes.
Okay.
Yes, ma'am. Please go ahead.
Yes, yes. So I bring all my best wishes to AMOGS, the land of real, the Lord of Chivalry, Shivaji, and again Ganpati Maharaj, which has become really a global phenomenon now. So thank you again, AMOGS. So, and I also bring you greetings from the land of Lord Jagannath, from where I belong. So I'll be speaking to you on now recent advances in management in ovarian cancer. So I think at the same time, it's important to know some basics also, because just knowing recent advances is not enough. So it will be a little amalgamation of both the basic principles. So before you start managing a case of ovarian cancer, I think you have to learn a lot about the imaging, because that's the most important thing. So I think we always depend on a radiologist for our imaging. So I think for my young colleagues who are here, please learn to read your own CT scans, so that when you open the abdomen, you don't get surprises of what you have never expected. And at the same time, I'll also like to mention that if you have a very good ultrasound, please don't lose heart that I don't have a CT scan available in my area or whatever. So a very good ultrasound is also equally good. So I think done by a good sonologist with a good probe will also give you quite a lot of information. So I think imaging is a very important thing, along with tumor markers, along with your clinical examination. The idea of telling you all this is that we should not lose the first chance of surgery. So if you think that it's a very advanced disease, I will not be able to do justice with the patient, I think it's always better to send her to a center where it can be done, because always the first surgery is the best surgery. And we'll just be talking about that in a little while. So as we know, surgery is the cornerstone of management of ovarian tumors and cancers. And basically, they can be divided into two groups. One is called a primary surgery. The other is the secondary surgery. Primary surgery can be again divided into two groups. One is for limited disease, another is for advanced disease. So for limited disease, it's usually for early stage 1 and 2. It's usually called a surgical staging, or if the patient is young, desirous of childbirth, and we may think about conservative surgery, and we'll be coming to that in a little while. What are the cases in which you can do a conservative surgery? For advanced disease in stage 3 and 4, it's usually called a cytoreductive surgery or a tumor reductive surgery. And the other types of surgeries are interval TRS, which is done after giving chemotherapy when we think it's not possible to do a surgery at the outset. And second look laparotomies are now obsolete because of very good imaging and tumor markers. And sometimes secondary surgeries are also necessary when the patient becomes symptomatic or recurs in various sites after the primary surgery is over and after the chemotherapy is over. So secondary laparotomy is now not being done. Only the secondary TRS is done in recurrent settings. So usually most of the time the women will be having a huge abdomen, maybe obese also, and maybe in the elderly age group. And so this is the main thing we have to remember, that we have to put aside aesthetics here, and liberal vertical midline incision is the best way, because I think viewing all the structures and removing all the structures is that matters and translates to years of life than doing a minimal surgery and leaving the disease inside. So first let's look at primary surgery. It's usually criteria to be fulfilled for conservative surgery. So this is a surgery where we plan to keep the fertility intact. So the consent is very important, appropriate counseling. There should not be any evidence of any dysgenetic gonads. And the specific situations are a unilateral germ cell tumor, unilateral sex-cord stromal tumor, unilateral borderline tumor, and of course a stage 1A, 1C or 2A epithelial ovarian cancer. But then we have to do a very appropriate counseling in this. So in germ cell tumor, sex-cord stromal tumor and borderline tumor, we are it's a little more liberal decision to take, but in epithelial we have to take the decision very cautiously. So usually it should be a vertical midline incision, evaluation of the ascites, complete abdominal inspection, excision biopsy of suspicious areas, multiple intraperitoneal biopsy, and a total abdominal hysterectomy, bilateral salpingoophorectomy, infracolic omentectomy, selective lymphadenectomy, and appendicectomy. So 20 to 30% of the so-called early disease will also have positive lymph nodes. So that's the reason why we do a lymph node staging even in early stage disease. And so, but exceptions of doing a THBSR when you are planning for a conservative or fertility sparing surgery. But that's again in which we have to do everything else, including a lymphadenectomy, leaving behind the uterus and one side of the ovary. So this is the surgical specimen after the surgery. It's usually both the ovaries, the tubes, the nodes, and peritoneal washings. And the momentum is taken out, and now the removing the appendix is now a little controversial whether to remove or not to remove. But in a mucinous tumors, it's wiser to remove the appendix. So coming to the procedure, it has to be a meticulous surgical staging. Negative if peritoneal washings, negative omental biopsy. You can do a unilateral salpingo-oophorectomy of the affected site. Unaffected ovary should be spared from any biopsy even, because it leads to adhesion, ovarian failure, and maybe some mechanical infertility also. So if you think you are doing a conservative surgery, it's better to leave the ovary behind and not touch the normal ovary. And my biopsy may only be done if it looks very suspicious. And then again, you have to cover it up with Intracid to avoid adhesions. So ovary conserved should be removed after childbearing in epithelial ovarian cancers only. We can leave the patient as such if it is a germ cell tumor or a stromal tumor. So this is a germ cell tumor of the ovary. Here you can see she is one of our patients who the other side ovary is completely normal, and she has gone ahead, married, and had a good life. So dysgerminoma, again coming to one of the germ cell tumors, is the commonest. It is a highly chemosensitive and radiosensitive tumor. So it's usually a solid tumor in younger age group and has a propensity for lymph node metastasis. So here the treatment of patients with early dysgerminoma is primarily surgical, including the resection of the primary lesion and proper surgical staging. Chemotherapy is administered to metastatic disease. Special consideration for preservation of fertility and use of chemotherapy whenever possible. So I think these are very curable cancers. So staging laparotomy when neoplasm appears on inspection to be confined to the ovary. A careful staging laparotomy should be undertaken. All peritoneal surface should be inspected, areas palpated. So I think it's very important, because if you miss out some metastatic disease, maybe on the upper surface of the liver, under surface of the diaphragm, that's a stage 4 disease. So I think a proper inspection is very, very important. And these small diseases may be missed by imaging also. So I think we have to do the proper inspection and palpation, and excisional biopsy of multiple peritoneal sites also. Any adhesions anywhere have to be biopsied. So surgery when appropriate should be unilateral oophorectomy. This is about the germ cell tumor, dysgerminoma especially, and there is no role of systematic lymphadenectomy in all malignant germ cell tumors because except dysgerminoma, most of them are not lymphotropic, so they don't need to do a lymph node dissection. And especially when you get a patient who has come to you with already a surgery done with a unilateral salpingo oophorectomy with a report of a germ cell tumor, it's not necessary to go back and do a revision surgery because we have good imaging with us, we have good tumor markers, can follow these patients up, and if required can give them chemotherapy also. So selective lymph node sampling versus systematic lymph node dissection for malignant ovarian germ cell tumors, palpation of the pelvic and parotid lymph nodes is recommended among surgical procedures required for adequate staging. In particular, dysgerminoma presents a strong lymphotropism, others are not so. An exception might be very early germ cell tumors without indication for an adjuvant chemotherapy. Unilateral pelvic lymph node dissection is usually done if a tumor is less than 10 centimeters. Although routine lymphadenectomy has not been introduced and in international consensus for germ cell tumors, it should be at least be implemented in patients with dysgerminomas and mixed germ cell tumors where they already also have an element of dysgerminoma. So should we do a omentectomy or not do a omentectomy in patients of germ cell tumors? So in conclusion from this huge study, they showed that omentectomy in patients with clinically early stage germ cell tumor may not improve the patient's survival and may be omitted. So there's no need of doing a omentectomy. You can do a omental biopsy though. So coming to restaging, what I've told, if a patient has already come to you with a biopsy report, what should you do? So one, a pure ovarian dysgerminoma prognosis is excellent. Conservative surgery with a complete surgical staging is the gold standard. Patients with incomplete staging should undergo surgical restaging or surveillance. Chemotherapy should be reserved to relapse with excellent chances of therapeutic success. So you have the option whether to do or not to do. So that's up to you to decide. So coming to chemotherapy, platinum-based chemotherapy is regarded as the treatment of choice. The obvious advantage is the preservation of fertility. The most frequent used chemotherapeutic regimen is BEP, which is given in the form of bleomycin, etoposide, and cisplatin. And other regimens are usually EP or EC can also be used and usually given 3 to 4 cycles. Second look surgery, in general, second look surgery is not recommended in germ cell tumors. Secondary surgery is sometimes used that survival of patients with immature teratoma who underwent secondary surgery was superior to those with other histologic types, particularly patients presenting with growing teratoma syndrome. So this is an important complication and appears as a recurrence of usually immature teratomas, and the ideal candidates for such consideration would be those with an isolated focus or limited foci of recurrent tumor. So this about 75% of recurrences occur within the first year after initial treatment, and the most common sites are the peritoneal cavity or the retroperitoneal lymph nodes. Treatment is usually chemotherapy. So if prior treatment BEP has already been given, we can also change over to paclitaxel, ifosfamide, and cisplatin or VIP. Radiation therapy is effective for this disease with a major disadvantage being loss of fertility. So that's taken with a pinch of salt. So these are specimens of unilateral salpingo oophorectomy. So when you are doing a unilateral salpingo oophorectomy, please be cautious that you remove the entire ovary and not leave behind a chunk of it. Especially, we tend to do that when we put the clamp on the IP ligament more towards the ovary. So it's important that we dissect the IP ligament or the ovarian vessels and take the clamp a little away from the ovary so that the entire ovarian tissue is removed. So coming to sex cord stromal tumors. So sex cord stromal tumors can occur as young as in 6 years old. Here you can see it's called a juvenile granulosa germ cell granulosa cell tumor. The operative management is again surgery, following the same principles: peritoneal washing, cytologic assessment, inspection, palpation. Resection of the ovarian tumor constitutes sufficient therapy for essentially benign neoplasm. This is a so-called benign neoplasm unless it has a high mitosis or is a high-grade tumor, and can be performed through open route or in selected cases by laparoscopy because patients are young and with about fertility preservation. So upon histologic confirmation of a granulosa cell tumor, intermediate or poorly surgical staging is required. Following careful surgical staging in the absence of extra ovarian disease, conservation of the uterus and contralateral ovary is reasonable in patients wishing preservation of the fertility. So that is an option in granulosa cell tumors. So for older patients or those with advanced stage disease of bilateral ovarian involvement, TH-BSO is indicated. there are reports of conservative management of patients with advanced juvenile granulosa cell tumors also, because they occur in younger patients with cytoreduction chemotherapy, leading to prolonged disease-free intervals and multiple pregnancies. So if the uterus is preserved, a thorough curettage has to be done, because sometimes these tumors would harbor, the uteri would harbor estrogen producing, because these are estrogen producing tumors, it could harbor endometrial hyperplasia or very rarely endometrial cancer too. So although no randomized evidence exists pertaining to the efficacy of cytoreduction in stromal tumors, on the benefits observed with their epithelial counterparts, and aggressive maximum effort should be taken if they are metastatic or a very advanced disease. Value of secondary cytoreduction continues to be controversial, and a repeat cytoreduction frequently affords this patient extended palliation. So these tumors usually tend to recur very late, and we have to keep them under follow for a quite long time. And if they recur, again the treatment is surgery. So coming to early epithelial ovarian cancer, so here you can see these are some of the pictures of these patients. So here you can see it's called a capsule rupture. So what is capsule rupture? So here you can see that there's a capsule rupture on the ovarian surface. So removal of the mass and imprint cytology and frozen biopsy. So it's ideal to do a proper diagnosis before surgery. But in case if you're still in dilemma on the OT table also, please remove the specimen in toto and send it for frozen biopsy. And if that is also not available, you can go ahead with the imprint cytology. Talk to your pathology friend beforehand, keep him or her ready, and send the tumor immediately without formalin, and they can take an imprint cytology. And we have done a study on this and seen that the corroboration is quite good. So if you don't have a frozen biopsy, you can also go with the imprint cytology, because many times your treatment will depend, especially in the younger women, whether to do a fertility preservation or not. So usually the methods are abdominal hysterectomy and bilateral salpingo-oophorectomy, followed with omenectomy, peritonectomy. That's the important part, because it's basically a peritoneal disease. There are a lot of peritoneal deposits most of the time, and followed by pelvic and para-aortic lymph node dissection. So here you can see the specimen, and it's so important to cut open the uterus also, because many times there is a along with the ovarian cancer also, we could have some uterine cancers also could coexist and are called synchronous endometrial ovarian cancer, and here is a specimen for that. So FIGO recommendation for stage 1 is dense adhesions with histologically proven tumor cells justify upgrading to stage 2. If rupture is noted, peritoneal washing and cytology study are indicated. So in apparent early stage ovarian cancer, again, the presence of isolated omental metastasis is relatively rare. So for staging purposes in such cases, random omental biopsy rather than total omentectomy may be good enough. Chemotherapy appears to effectively treat microscopic disease, and therefore, if this is already planned, the benefit of omentectomy is unclear. So what are the limits of omentectomy in early disease? So it's better not to perform a total omentectomy in early stages, as omentum engulfing the cancer cells delays their spread to the serosal surfaces and upper abdomen, leading to an omental kick. So if the omentum is healthy, it's not necessary to remove the entire omentum, because if you leave a portion of that in the, if there is a recurrence, this omentum will take care and prevent its spread to the upper abdomen. So there is limited evidence that a total omentectomy with the objective to remove an unrecognized occult disease in the intragastric omentum benefits the patient. So the moral of the story is that it's not necessary to do a total omentectomy in early stage disease. And similarly, this is again another study which has shown us the same thing. However, the utility of peritoneal biopsy and omentectomy, the upstaging of apparent early ovarian cancer, shows that random peritoneal biopsies and systemic omental biopsies are still indicated in early stage disease, owing to the low morbidity of the procedure and a small but present possibility of upstaging and altered management. So whenever, if you think also that it's a very early stage disease, taking multiple biopsies from the peritoneum and omental biopsies is important. So coming to borderline ovarian tumors, for borderline ovarian tumor, positive lymph nodes are found in the tune of 7 to 23% of the serous subtype and 0 to 5% in the mucinous subtype. So lymphadenectomy has no prognostic or therapeutic role in borderline ovarian tumors, and hence it's not indicated in borderline ovarian tumors. However, all enlarged nodes have to be removed, and if you have done a proper imaging and if you have seen there are enlarged nodes, I think they need to be removed. So lymphadenectomy in ovarian neoplasms, again, of positive lymph node in presumed early stage ovarian carcinoma is also there. So I think it has to be done. Lymphadenectomy is a part, and it has to include all the pelvic lymph nodes, including peritoneal lymph nodes up to the renal vein. So here you can see the picture of the left renal vein. So it's a proper clearing of all the lymph nodes up to the renal vessels. So these are the areas where we usually remove the nodes from the external iliac, from the obturator, from the internal iliac, from the presacral. So all have to be cleared properly. And these are the areas of the para-aortic lymph node groups from which you have to remove. It's the inter-aortocaval, paracaval, para-aortic from all the areas. So it's a little technically, I understand it's really a little challenging, but I think it's not rocket science that no one can learn. I think you need a good supervisor and learn it from them, and then it comes. So when you start doing, please call a friend who is already doing all this process, work with them, and gradually you'll pick up all this. So incidence of lymph node metastasis, the rate of positive lymph nodes in patients with presumed early stage disease is again 15%. Highest rate of positive nodes are reported in high-grade serous histological types and the lowest in mucinous subtypes. So in mucinous subtypes, you may think about doing it or not doing it. So the mean incidence in unilateral tumors, again, the pelvic lymph node metastasis is found to be 9.7% on both sides. So if you are, even if in a unilateral tumor, it's important that you do it on both the sides. So what is adequate lymphadenectomy? So it's 25 to 35 pelvic nodes and 12 to 25 aortic nodes. That's the adequate lymphadenectomy. So in early ovarian cancer, the aim is to remove suspicious and even clinically unsuspicious microscopically positive lymph nodes, so that histologically we confirm the disease and it may become upstage, and so the chemotherapy will be planned. So it has been shown by several authors that complete surgical staging, including pelvic and para-aortic lymphadenectomy, shows better prognosis compared to incomplete surgical staging. And similarly, a prospective study in ovarian cancer limited to the pelvis showed a 22% rate of lymph node metastasis diagnosed by systematic pelvic and para-aortic lymphadenectomy. So complete surgical staging, including systematic lymphadenectomy, should also be performed in patients with fertility preserving surgery. So that is the important thing. So coming to advanced epithelial ovarian cancer, here you can see a huge metastatic deposits on the mesentery of the bowel. So the surgery for this is called a tumor reductive surgery. So the benefits are that we improve augment of tumor response to further therapy by improvement of tumor perfusion, removal of large tumor and omental cake reduces ascites, so that's improvement in the nutritional status, and enhanced immunological competence and a psychological relief, of course. So the procedure is again the same. The procedure is called a radical oophorectomy, in which a retroperitoneal approach is taken to remove the pelvic extension of the ovarian cancer, because most of the time you'll find a huge mass with the entire uterus and both the ovaries fixed to the pelvic side walls. And this would also include a total omentectomy, because many times the omentum is also involved, and sometimes it will also entail a resection of the rectosigmoid small intestine to achieve R0 resection. So here you can see that the ovarian tumor has been removed, but there's a huge deposit on the sigmoid. And so in these cases, you need to go retroperitoneally, and this is called a retrograde hysterectomy on the sigmoid and the pouch of Douglas. The lesion is there. So it's called a retrograde hysterectomy, in which we open the anterior vaginal wall, then open the posterior vaginal wall, enter into the rectouterine space, and then remove the mass in toto along with the uterus. So that's called a retrograde hysterectomy. And sometimes a portion of the sigmoid colon needs to be resected in case there's injury or there is deposit, and then a colostomy performed. So this is a specimen which shows entire peritoneum of the pelvis has been removed, and along with the uterus, so it looks like a bat actually. So radical oophorectomy is the removal of all the pelvic tumor, is termed as radical oophorectomy, and it's usually a retroperitoneal approach to remove the pelvic extension of the ovarian cancer and the internal genitalia. So treating advanced cancer is a real challenge to the surgeon. From a surgeon's perspective, advanced ovarian cancer is more a peritoneal disease rather than a retroperitoneal disease. We have many predictive models and strategies by which we can know whether we can do a proper surgery or not. So these are many scores which you can do this before you embark on the surgery. It's called a Fagotti score. This is done by laparoscopy. There's a modified Fagotti score. So if you see that the score is very high, you have extensive diaphragmatic carcinomatosis, mesenteric retraction, stomach infiltration or liver metastasis. I think these are the cases in which studies have shown, like the EORTC and the CHORUS trial have shown that you can give neoadjuvant chemotherapy in these cases, and usually 3 cycles followed by an interval debulking surgery followed up again with adjuvant surgery, and the survival rates are almost equal. But the morbidity, the blood transfusion, the operating time, everything is less. So when you think that it's an inoperable case, you can still go ahead, give chemotherapy and operate after 3 cycles of chemotherapy. But just to remember that if you are planning neoadjuvant chemotherapy, it's so important to have a pre-operative biopsy of this patient, and is usually done by an image-guided core biopsy. So, and you need to do the IHC also of these patients, because we don't know what type of tumor it is before we start chemotherapy in this patient. So, neoadjuvant chemotherapy has been proposed as an alternative in advanced epithelial ovarian cancer patients with low performance status, underlying morbidity, older age, or disseminated unresectable disease. So this is a specimen of a radical oophorectomy in which you can see that the en bloc removal of the uterus, ovaries, and the involved sigmoid column. So in advanced ovarian cancer, again, the omentum will be something like a cake or will be completely studded. So in these cases, the limits of omentectomy are complete omentectomy, including from the hepatic flexure up to the splenic flexure, and very rarely you would need to remove the spleen also along with that because of the dense adhesion and splenic involvement. So the technique of omentectomy is generally not challenging except in the case of massive involvement, but some complications like bleeding, gastroparesis, stomach or transverse colon injury may happen, but it's very, very rare if the proper technology and safety methods are followed. So lymphatic dissemination, we have discussed about that. So this is about lymph node dissection. In advanced epithelial ovarian cancer, there is no survival benefit whether you do a lymphadenectomy or you don't do a lymphadenectomy. So lymphadenectomy does not have a much important role in advanced epithelial ovarian cancer. But at the same time, I have to tell you that you have to remove all the enlarged lymph nodes. You can't leave them behind. If it's possible that you are achieving a R0 resection, that's any disease, no visible disease, you can do a lymphadenectomy. So systematic lymphadenectomy is not indicated in patients with borderline ovarian tumors, sex cord stromal tumors, or germ cell tumors in cases of clinically or radiologically negative nodes. But in NCCN guidelines, if a parietic lymphadenectomy is planned, the dissection has to be performed up to the renal veins. So there are sometimes indications for splenectomy also if there is a splenic metastasis, perisplenic tumor infiltration, or intraoperative trauma. So this is a more important cause because splenic metastasis can be seen preoperatively. Perisplenic tumor infiltration can be seen on imaging, but sometimes intraoperative trauma, you cannot plan that. So we have to be sometimes prepared for that, and needs to be done in some cases. And so sometimes distal pancreatectomy also has to be done if there is infiltration. So this is called a CC score. So after the end of the surgery, you have to see how much you have removed and how much you have left behind. So what you have removed is not important. What you have left behind is going to survival benefit. So the indications of chemotherapy we have already discussed. So yeah, image guided true cut biopsy and IHC before chemotherapy is important. So this is called interval cytoreductive surgery or IDS or interval debulking surgery. So these are the indications. It's usually done after 2 to 3 cycles of chemotherapy. So the advantages are that we do an increase of optimal debulking, less aggressive surgical approach, intraoperative complications are less, mortality and morbidity is less, and the quality of life is improved. So in recurrent ovarian cancer, you may face some cases, but as general gynecologist, you may not, but there are situations and sometimes they would need some kind of surgery to be done. So what are the indications where surgery has to be done? So surgery is not beneficial if you are not going to give a complete gross resection. If you are ready to do a complete gross resection, then only you go ahead and do a surgery. So these are, you can score these patients whether you will be able to do a complete gross resection. These are 3 trials who have shown that if you are giving a complete gross resection, there is a survival benefit, and if it's not possible, then please don't do it. So then PIPAC, these are new chemotherapeutic measures, but these are being done by surgical oncologists only, gynec oncologists, in which chemotherapy is given then perfused into the peritoneal cavity, mechanized perfusion with pressure. And this is again hyperthermic intraperitoneal chemotherapy, which has a role especially after interval debulking surgery, in which the chemotherapy is left in the peritoneal cavity at a high temperature and is continuously perfused, and then it's removed. It's a little morbid procedure, but giving good results. So this the techniques are either open method or a closed method. So the role of HIPEC in ovarian cancers is coming up more lately. We have many large trials which are showing that there is a survival advantage. So then there's a small points to remember is that there in the recent past we have seen increased incidence with endometriosis and adenomyosis, especially endometriotic cancers and clear cell cancers. So these are the two cancers which are rising, and because we have a rising incidence of endometriosis and adenomyosis, and whenever we are doing a surgery for endometriosis, it's so important that we send the specimen for biopsy, because many times some occult cancer may be there. So BRCA testing is an important thing which is now changing the paradigm of management of ovarian cancers. And sentinel lymph node identification also is in early stage ovarian cancer is slowly gaining momentum, so that whether to do or not to do will be decided. So PARP inhibitors, these are used in women with BRCA mutations. They are olaparib, rucaparib, and niraparib, and are really new avenues. Though the rates are very high now, we are looking at them so that women with ovarian cancer will have a good survival benefit with these PARP inhibitors, which are a type of targeted therapy. And so clear cell ovarian cancers are now having a newer outlook totally. So they have many types of biomarker which need to be established with this clear cell carcinoma, which are also shared with endometriosis. So surgery is an important component in the management of ovarian cancer. Additional surgeries after primary chemotherapy may be of value, while secondary surgical cytoreduction may be well accepted. The context in which it is to be employed is still being developed, and its absolute benefit still has not been established by randomized clinical trials. So the moral of the story is that first surgery is the best surgery. So I think I should know what is my limitations, whether I can do a proper surgery. If I cannot do a proper surgery, I'll call a friend, or I will send the patient to a center where she can get the best of the treatment. And the time spent in OT really translates to years in life. So if you pick up all the small disease and give a R0 resection to the patient, so that will ultimately give her a high overall survival than leaving behind disease. If you leave behind any disease which is the size is more than 2 centimeters, it's as good as doing no surgery at all. So I think we should be very careful in choosing our cases in which we can do them. So and as with passing time, we have become more and more conservative, and fertility preservation surgeries are being done as we have understood the disease, about the lymphotropism, about imaging, about tumor markers. So more and more conservatism is being followed nowadays. But then this is a very important question: appropriate staging, who should operate? So 97% appropriate staging is done if it is operated by gynecologist, 52% if staged by a general obstetrician gynecologist, and 35% if staged by general surgeons. So it's not fair to say that, but many of our ovarian cancers are being operated by general surgeons. So I think our gynecologists should take training, take help of your seniors and do the surgeries. And so better prognosis if surgery is performed by a gynecologist. So that has been approved beyond doubt. So thank you very much for your attention. So Dr. Pratik, do I have time 5 minutes for my?
Yes, ma'am, please go ahead. No worries.
Okay, thank you so much.
Do we have any time for one question, Dr. Pratik?
Yes, ma'am. Usually we take the questions at the end of the session after all the three speakers have finished, so that we don't keep them waiting. I think Dr. Bhagyalakshmi wants to share a video.
Yeah, I must congratulate Dr. Bhagyalakshmi Nayak. She has covered such a vast topic in such a short period. It was an excellent talk, and it was pleasure hearing you, ma'am.
Thank you, sir. Sir, I'll take just 1 minute.
Yeah, no problem.
If you're facing difficulties, ma'am, can we come back to it a little later? Is that all right?
It's done. So here we are. I hope you can see it now.
Yes, we are.
Yes, ma'am. Please go ahead.
Yes, yes. So the ovarian tumor has already been removed. So I'm not going to the ovarian tumor. This is just to show you about the lymph node section and the omentectomy. So here we are removing the lymph node. So these are all the instruments that anything you can use your bipolar forceps also. So here you can see this is the psoas muscle on the lateral side. These are the external iliac vessels and this is the genitofemoral nerve. So once you remove the node, so this is actually a sentinel node which has been removed and is showing to be green color. So you can also do that sometimes. It's so here you can see this is on the other side, and here you can see that all the retroperitoneal structures have been exposed. Yes. So here again the lymph nodes are being removed. So usually this is the bipolar forceps which is being used, and this is so here all the nodes have already been removed, and here you can see this is the artery which is continuing as the internal iliac arteries division. And so these are all the structures from which the lymph nodes have already been removed. So this is the iliac artery. So this is the extra iliac vein. So this is the operator fossa from which all the lymph nodes have already been removed. Okay, so go ahead a little faster. So let's see. This is the omentectomy which is being done. So the most important thing is that you have to identify the omental margins where it arises, and usually we start from the hepatic flexor and end at the splenic flexor. But before doing that, the first step is that we throw the omentum cephalad. It's almost placed on the thorax of the patient. And here again you can see that we are using the bipolar forceps. You can use a monopolar as well. So here you can see that the monopolar forceps is used, and monopolar cautery, it's usually coagulation and spray, and usually the spray mode we are using. So here you can see that the lesser sac has completely been opened, and here this is the pancreas which is being shown. So but I think as gynecologists rarely get to, while doing the benign surgeries, we rarely get to see the structures, but I think they are very forgiving organs and hardly ever they can get injured. So in my life, I think in my 20 years of practice of oncosurgery, I have injured the spleen 3 times totally, and only once I had to remove the spleen because of the injury. So I think hardly any time, and once in a while you could have a hematoma also because of the big vessels. So, and this is again a very safe vessel sealer device which you can also use. Okay. So, and this is about para-aortic lymphadenectomy. So here you have to open up the retroperitoneum very widely because you need to see all the structures. So this is just, we are going along the margins of the cecum on the right side and the sigmoid on the left side. So here you can see the entire retroperitoneum is being opened up. So all the bowel is retrieved from the abdominal cavity is placed again on the patient's thorax, and we really keep it covered with some normal saline soaked swab so that it doesn't dry up, and then we enter into the retroperitoneal structure, into the paracardic space. So here you can see that this is the left renal vein. We have gone almost up to the left renal vein. So this is the left renal vein. So these are all the lymph node structures which are being removed. So here you can see the pulsating aorta. After, once you enter into the retroperitoneum, you identify the inferior mesenteric artery. That's one limit, one important structure which needs to be identified. The hypogastric nerve plexuses also needs to be identified. So here you can see very clearly, this is the last node which has been removed. This is the left renal vein which is seen, and this is the aorta which is pulsating. And here we have removed also the inter-aortocaval nodes. And so this is the anterior spinal ligament, the white structure which is being shown. Yes, sir. So that was the last node. So here you can see that the infundibulopelvic ligament, the vessels which drain have been tied at the pedicle has been tied at its insertion. So these are all the nerve fibers which have been preserved. These are again on the other side, the paracaval, para-aortic nodes are also removed from the other side. So this is the end of the process. So this is only for visualization of all the structures. The ureters on the both sides are there. So this is the ureter which you can see so nicely crossing the vessels. I think they are all friends actually. We really get so afraid of these structures when we are not seeing them regularly. But I think once we start doing, they all really appear like friends to us on both the ureters, the aorta, the IVC. And so I think we all can learn and do this process. It's not rocket science, I think. And doing it by open is easier. And of course, people are also doing it by minimal invasive surgery. And that's the learning curve is a little more than open. But I think you should first need to learn open and then do the minimal invasive. So revision surgeries can also be done by minimal access procedures. Thank you so much, Dr. Pratik, for giving me this extra time.
Most welcome, ma'am. Thank you for a lovely talk, evidence-based, updated. You covered so many different tumors. It was like a crash course in oncology for all
Exactly.
of us.
Exactly.
Thank
I
you
wish
so much.
all my junior colleagues to start learning and taking a little interest in oncology than only infertility. So that's
video demonstration was also excellent.
Thank you, sir.
Very detailed demonstration of all the anatomy.
Thank you, sir.
Thank you so much, Dr. Bhagyalakshmi Nayak and Dr. Sagar Kataria, sir. We move on to the next speaker of the day. We have with us Dr. Rekha Chote, who is the Secretary of the Thane OB/GYN Society. And for her formal introduction, I would request Dr. Shashmita Das to please do the honors. Session, can we have the introductory slide, please?
Good afternoon, everyone. Thank you, Dr. Pratik. Let me introduce Dr. Rekha. And she has done a course in advanced gynec endoscopy. She is a gynec endoscopic surgeon, and she is interested in high-risk OB/GYN practice. And for last 20 years, she is doing. She is also a colposcopist. She is the co-head of occupational cure group of hospitals. She is the honorary laparoscopic consultant and Family Planning Association of India and Thane. She is the Secretary General of Thane OB/GYN Society, recipient of Mrs. Intellectual title in International Beauty Pageant held in Moscow, Russia. Wow, in 2017. Congratulations, Dr. Rekha. Recipient of Thane's prestigious Navadurga Award also in 2017. So highly talented, Dr. Rekha, please go ahead and welcome to this webinar.
Thank you, Dr. Reena Das, for a kind introduction. I'll share my screen now. At the outset, I would like to thank Dr. Nandita Palshetkar, Madam, a President of AMOX, and Dr. Arun Nayak, Sir, for Secretary General of AMOX, and my dear friend and my Gawala, Dr. Pratik Tambe. Okay, let me just see this. Yeah. So my topic is a medical management of fibroids, uterine fibroid. I think I'll just escape this. Okay. Okay. Incidence of fibroid in India. The common concern at fertile age, everybody knows multiple bleeding and pain symptoms affecting the quality of life. 20 to 30% of the women in reproductive age group have uterine fibroids. At any age, nearly 15 to 25 million Indian women have uterine fibroids. So everybody knows about the types of uterine fibroids. 75% are intramural fibroids, submucosal are 15%, subserosal 10%, and pedunculated submucosal, subserosal fibroids. Symptoms of uterine fibroid: menorrhagia, dysmenorrhea, pelvic pain, urinary incontinence, infertility, and anemia. Now, treatment option for the fibroid, we have a surgical treatment and medical treatment. Surgical treatment includes a hysterectomy, a laparoscopy or open, myomectomy, and uterine artery embolization. Medical treatment contains NSAIDs, antifibrinolytic, GnRH analogs, progestins, danazole, and combination oral contraceptive pills, and SPRMS, that is selective progesterone receptor modulators. Medical management of fibroids. Current treatment options, we have SPRMS, that is selective progesterone receptor modulators, combined hormonal contraceptive, levonorgestrel releasing intrauterine device, oral progestins, androgens, that is danazole, GnRH agonist, non-steroidal anti-inflammatory agents, and antifibrinolytic. Natural medical options are triptychum wilfordi, that is WA, then epigalactogallate, that is EGCG, and vitamin D. A future treatment may include asuprensil, elagolix, and relugolix. Now we have a limitation for surgical therapy. Like a hysterectomy, definitely a morbidity increases, a surgical risk of a surgical long-term complication, and very important is a complete loss of fertility. Myomectomy, again, fibroid recurrence, potential uterine rupture during pregnancy and delivery. And uterine artery embolization, again, a recurrence of fibroid can happen, pain, possibility of severe complications, possibility of a subsequent hysterectomy in 20% of cases, needs interventional radiologist, potential ovarian failure, abnormal placental development, and definitely it is a very costly procedure. GnRH analog. Okay, GnRH analog is rapidly metabolized decapeptide, which is produced and released from anterior hypothalamic area, reaches the anterior pituitary through portal system, believed to bind to specific receptor in the anterior pituitary, stimulates the synthesis and secretion of luteinizing hormone and follicle stimulating hormone in both men and women. Its half-life in the peripheral circulation is 2 to 4 minutes. To increase the potency and duration of GnRH, analogs with agonistic or antagonistic properties have been synthesized and are available for clinical use. GnRH analogs mimics the innate GnRH and desensitize the receptors and further inhibits LH and FSH stimulation. 35 to 65% reduction in size of fibroids and uterus can be achieved. Reduces intraoperative blood loss, decreases hospital stay, and helps convert some laparotomies into a minimal invasive procedures. Regrowth of fibroids to pretreatment size within months of cessation of GNRH therapy, that is a drawback, may make a surgical plans indistinct. That is, myomectomy is followed by the analog is definitely a difficult. Either it is a laparoscopy or open. Preoperative depot-lipoid 3.75 milligram per month for 3 months is the only FDA-approved GNRH analog. Now, selective progesterone receptor modulators, that is ulipristal acetate, originally used for medical termination of pregnancy at higher doses, came in use following the discovery that progesterone plays as an important role as estrogen in fibroid growth. Lower doses for reducing the myoma size and managing the symptoms. Now, how does it act? It acts on a fibroid. It decreases the fibroid size and volume by shows an anti-proliferative action. It acts on the HPO axis and inhibits the ovulation, and it acts on the endometrium and induces the amenorrhea. Now, again, we have a limitation of medical therapy. NSAIDs is a lack of supportive evidence from clinical trials, gastrointestinal side effect, risk of gastric ulceration. Tranexamic acid has used to treat menorrhagia and dysmenorrhea, can increase the size of myoma. GnRH agonist causes hot flashes, vaginal dryness, and decreased libido. Increased bone mass loss, increase the risk of osteoporosis. Use is limited up to 6 months, not safe and contraindicated in adolescents. Painful injections, low compliance, risk of recurrence, and expensive. Danazole again can cause acne, hirsutism, edema associated with liver toxicity, adverse effect on lipid metabolism and weight gain, musculoskeletal pain. Progestins used to treat the menorrhagia and dysmenorrhea, breakthrough bleeding, and can increase size of myoma. A combination oral contraceptive pills, breakthrough bleeding, not safe for long-term use and can increase the size of myoma. Now, Pharmacovigilance Risk Assessment Committee, that is PRAC, recommends revoking marketing authorization of ulipristal acetate for uterine fibroid. They said that ulipristal acetate can cause liver injury, including need for liver transplant too. Patients at risk or measures to reduce the risk could not be identified and recommended to revoke the marketing authorization. Pathophysiology of uterine fibroid is an estrogen and progesterone plays a vital role in development in uterine fibroid. Estrogen and progesterone receptors are more in fibroids compared to normal myometrium. Estrogen and progesterone binds to their respective receptors, increase secretion of growth factor, fibroid cell proliferation, and that is how the growth of fibroids happens. Newer pathological factor is a COMT in uterine fibroid, that is catechol O methyltransferase, an enzyme that is recently linked to the pathogenesis of fibroid. COMT is highly expressed in uterine fibroid compared with normal myometrium. Now, COMT converts the hydroxyestradiol into methoxyestradiol, which is a estrogen activity. Role of transforming growth factor beta in fibroid. TGF-B2 is elevated in a fibroid compared with myometrium, and it gives rise to extracellular matrix overproduction by inducing collagen type 1, fibronectin, and proteoglycan, key regulator of cell growth and differentiation, inflammation, and apoptosis. Now, influence of vitamin D and TGF-B3 serum concentration, obesity, and family history on the risk of uterine fibroid. Significantly lower 25-hydroxy vitamin D in a uterine fibroid patient. Thus, vitamin D may be a potential protective factor against the development of fibroid. Increased TGF-beta-3 concentration associated with increased risk of uterine fibroid. So, TGF-beta-3 may become a useful tool for detecting an increased risk of uterine fibroid. So, complete pathophysiology of uterine fibroid. Now we can say that increased estrogen and progesterone receptor expression, increased aromatase enzyme, increased COMT expression, and increased TGF-beta-3 expression. Now, these are the pathophysiology. So, need to take care of all these major etiological factors while treating the uterine fibroid. Need of novel non-hormonal therapy, taking care of all etiological factors of uterine fibroid, act on both progesterone as well as estrogen receptors, hit the newer target of fibroid, that is COMT and TGF-B3, safe and well tolerated. Novel non-hormonal therapy includes TW 20 milligram green tea extract, that is EGCG 400 milligram, and vitamin D3 1000 international unit. The main active constituents of TW is a triptolite. Novel non-hormonal treatment of uterine fibroid. This is a review study in 2008 where extract of TW has obvious effect on anti-inflammation, anti-tumor, anti-fertility, and immunoregulation, and is broadly applied in a various clinical departments. Referred to the gynecological disease, clinical therapeutic trials of TW on endometriosis, leiomyourea, and abnormal uterine bleeding and subtumors of women have been carried out, and it can be proved an effective new drug for treatment of gynecological diseases. Now, how does mechanism of TW? It inhibits the expression of estrogen and progesterone receptor, and thus reducing the estrogen progesterone biological effect on fibroid tissue, decreases anti-apoptic factor BC2, and increases apoptic factor caspase-3, inhibits aromatase enzyme, reversibly inhibits function of ovary and interrupt ovarian follicular development, so inhibits ovulation and induces amenorrhea, and that's how it reduces the fibroid side and menstrual blood loss. Cochrane review in 2013 shows that compared with conventional medication, TW may have a beneficial effect in reducing the volume of uterine fibroid. Now, how does mechanism of action of EGCG? EGCG has potent anti-COMT activity. So it hydroxyestradiol converts into a methoxyestradiol. This EGCG stops the conversion and thus has an anti-proliferative activity. Mechanism of action of vitamin D3 is a strong anti-fibrotic agent, reduces TGF-beta expression, reduces the expression of collagen type 1 fibronetic, decreases the extracellular matrix production, anti-proliferative agent, and reduces the expression of PCNA, that is proliferating cell nuclear antigen. So complete mechanism of non-hormonal therapy is a TW, EGCG, and vitamin D3. That is how it reduces the uterine fibroid. Now, clinical study of effect of TWF on uterine myoma. So there was a significant decrease. Result of this study was a significant decrease in a leiomyoma volume was detected in 39 of 65 patients after 3 to 4 months of TWF treatment, and 28 of 40 patients after 5 to 6 months of treatment. The decrease in the leiomyoma volume with TW treatment was time dependent, while 27.84% in 3 to 4 months and 51.6% in 5 to 6 months. 25 out of 65 patients were amenorrheic during the course of treatment. So conclusion is TW may be an effective therapeutic agent for leiomyomas with fewer side effects. Benefits of TW is decrease in a menstrual blood flow, increase hemoglobin level, decrease fibroid volume by 27 to 68%, decrease in uterine volume by 18 to 60%, decrease in progesterone level by 57%, decrease in estrogen level by 41 to 48%. So regularization of menses after 1 to 3 months of stopping therapy. Now, the treatment of symptomatic uterine fibroid with the green tea extract is a pilot double-blinded placebo-controlled trial. 33 premenopausal women with the myoma more than 2 cubic centimeter. So, green tea extract was given to 22 patients and the placebo to 17 patients. For 400 milligram BID, the outcome was the mean change in a uterine leiomyoma volume, the mean change in a fibrotic specific symptom severity, and the mean change in a fibrotic specific health-related quality of life. So mean total fibroid volume dramatically decreased by 32.6% in EGCG group. Placebo group shows an average increase of 24.2%. And EGCG group mean change in SS score was minus 25.28 and placebo group was plus 7.1. The quality life score increased by 20 to 7 in EGCG group, Placebo group increased by 2.19. Significant decrease in blood loss and increased hemoglobin with EGCG. Well-tolerated treatment. No adverse effect, no abnormality in liver function test. Conclusion, EGCG shows a promise as a safe and effective therapeutic agent for women with a symptomatic uterine fibroid. Such a simple, inexpensive, and orally administered therapy can improve women's health globally. Now, low vitamin D level are associated with the uterine fibroid. Correlation of low vitamin D with a uterine myoma, systematic review and meta-analysis of 9 studies with 1730 participants out of this 835 uterine fibroid patients and 895 control participants. The result was serum vitamin D level were significantly lower in a fibroid patient as compared to control. 32% reduction in a risk of uterine myoma with a vitamin D more than 20 nanogram per ml. The National Institute of Environmental Health Science, the uterine fibroid study enrolled randomly selected 35 to 49 years old women during 1996 and 99. The fibroid status was determined by ultrasound screening of perimenopausal women. So each 10 nanogram per ml increase in vitamin D will result in 20% of the lower risk of having uterine fibroid. 125 dihydroxy vitamin D3 reduces extracellular matrix associated protein expression in human uterine fibroid cell. Uterine fibroid express reduced level of vitamin D receptor. This might be risk factor for fibroid pathogenesis. 125 dihydroxy vitamin D3 may have a potential as an effective therapeutic agent for uterine fibroid treatment. Hypovitamin D and uterine fibroids, opportunity for the vitamin D supplementation. It was a randomized control study, 108 women with a uterine fibroid and hypovitaminosis D. So out of this, 53 was study group and 55 was control group. 50,000 international unit of vitamin D3 once per week for 8 weeks, followed by maintenance therapy of 2,000 international unit daily for a year. Against the control group, we did not receive any therapy. Vitamin D3 level increased significantly in study group. Rate of women with a progression to extensive disease was significantly lower in study group. Fibroid diameter and volume increased significantly in a control group. Conclusion is the supplementation therapy with 25-OH-D3 restores the normal vitamin D serum level in a woman with a small burden fibroids. In this woman, vitamin D supplementation seems to reduce the progression to an extensive disease, and thus the need of a conventional surgical and medical therapy also reduces. Vitamin D plus epigallocatine gallage is a promising approach to a uterine myoma. It's a pilot study that is 30 adult women with a uterine myoma. Treated group 25 microgram of vitamin D, 150 milligram of EGCG, and 5 milligram vitamin B6 given, 2 tablets daily. Against a control group, no treatment was given. The difference in total myoma volume, treated group decreased by 34.7% and control group increased by 6.9%. Treated group also had reduction in symptom severity and improved the quality of life. Symptomatic management of uterine fibroid, that is indication of medical management, is a preoperative management of uterine fibroid. Dosage is 1 capsule twice a day, minimum for 3 to 6 months, and therapy can be started from any day of menstrual cycle. Now, summary is medical management of fibroid reduces the fibroid size and volume, controls the anemia due to fibroid-induced menorrhagia. Menstruation resumes suppression disease progression, improves this health-related quality of life, safe and well tolerated. Now, advantage over hormonal therapy. In hormonal therapy acts on either progesterone or estrogen receptor. In non-hormonal therapy, it acts on progesterone as well as estrogen receptors. Hormonal therapy has a serious liver injury or with the uripristal acetate, where non-hormonal therapy has a safe for liver and kidney. Hormonal therapy to be taken first and 7th day of menstrual cycle, where non-hormonal therapy can be taken at any day of menstrual cycle. Thank you for patient hearing. Okay.
Dr. Rekha.
One second. Okay. I'll stop sharing now.
Dr. Rekha.
Yeah.
Very detailed presentation. You have covered A to Z. You have not left anything. Some points I agree, some points I don't agree. But can I have time, Dr. Pratik, to discuss now or at the end of 3 speakers?
I think, ma'am, we'll take the questions for Dr. Bhagyalakshmi because there are a couple of audience questions also for Dr. Bhagyalakshmi.
Okay,
Madam is
right.
still around. So I thought we could have questions for her before the next speaker joins in. Dr. Rakhi is a little delayed in her OPD. She is expected to join in another 5 minutes. Maybe we can have the questions for Dr. Bhagyalakshmi here. I think you wanted to ask something a little while earlier yourself.
Yeah. Dr. Bhagya is there? Yeah.
Yes, ma'am, she is here.
Yeah, Dr. Bhagya, first of all, I congratulate because I know her personally. She is a very active academically and working in a regional cancer center. Bhagya, my very simple question as a layman, do you practice routinely tumor board discussions because you are in a regional cancer center? The second point is that suppose we find it is difficult, where the regional center people refer the cases as higher center. As a layman, as a common practice, people, we send the patient to regional cancer center or medical college. Suppose you find it is difficult, yeah, you find it is debatable case, where you prefer to refer your case.
Yes, madam, thank you so much. So, our each and every case which we take up in our government hospital, it has to go through a tumor board. So, every day the tumor board sits and all the cases that are admitted are discussed, and then the treatment is management is finally planned. And number 2 is that for us as of now, I think most of the critical surgeries we are able to do, but there are some difficult situations like some organ preserving surgery. Suppose it's a sarcoma of the limbs or something which is not available in our center, some thoracic surgeries. And so in those cases, for us, our best center is Tata Memorial Hospital. So that's, I think, the temple of temple for all cancer surgeons and cancer doctors. And that's a different thing. But if you don't refer also, if you have some problem, we have a very good rapport with most of the doctors there in gynae oncology in Tata. So they're just a phone call away. So even sometimes on the OT table also, we have called Dr. Amita, this has come in the frozen section and what should we do? So then that's how actually we go ahead.
So tele consultation and
at all, because it's patient's life first of all.
Okay, thank you so much. Thank
Dr.
you.
Bhagyalakshmi, ma'am, thank you for an excellent presentation. There were a couple of questions from the audience, and since Dr. Rakhi is delayed, I just want to take them here if possible. The first one is regarding the utility of MRI. So we were told in undergraduate and postgraduate years that MRI will have a big role to play in non-invasive staging of CA ovary. That is what we learned. So there is a question which is appropriate from the audience, and they are asking, how often do you perform MRI preoperatively in your patients? And secondly, does it actually correlate with your intraoperative findings? Because what you see on MRI or CT scan or even ultrasound, which all of us do, may be very different from what you actually see on table once you open the patient. Do you find that there is actually upstaging intraop?
No, I think I'll have to confess that if you have done a proper imaging, I think many times it correlates. But in case it doesn't correlate and we find something different, then it's my homework that I'll have to go back to the imaging and see that I have missed it. the imaging was correct, but I have misinterpreted it. I have not interpreted it properly. So that's one thing. And number two is coming to which modality to choose. So if you have ultrasound, that's it's a good ultrasoundologist can also do a good job. If that's not available, you choose between CT scan and MRI. So when you think it's an early stage disease, you are not looking at the lymph node status. I think MRI is good enough. So if you're thinking that you're looking at lymph nodes, for lymph nodes, I think CT scan is a better option than MRI, because MRI has a little caveat about the lymph nodes. So that's my submission about that. Otherwise, especially I'll tell you about when you have a doubt between whether tumor is benign or malignant, especially endometriosis, or there is some malignant element in the endometriosis, I think MRI is a much better tool there than a CT scan. And of course, you know that there's no radiation in MRI, so a contrast enhanced MRI is also very, very good.
Thank you,
so I
ma'am.
think, and again, I'll Pratik, Dr. Pratik, just one second. So I think
Yes,
you need to talk to your radiologist also. So that's also important, because it's not possible for us to always be able to interpret everything. So if you are having a doubt, it's not clinically correlating with your clinical findings, with your imaging, please go back to your radiologist, discuss with them, sir or madam, I am finding this and this, but it doesn't correlate with what I am expecting. So it's always actually, if you talk or communicate, that works out better.
And there's one more practical question which somebody from the audience has asked. Obviously, it must be somebody who doesn't do cancer surgery like me. And they're asking whether you actually do the lymphadenectomy and the omentectomy first before you proceed to the pelvis, or is it AH, BSO first and then you go ahead and do the rest of the procedure?
That's the patient, the surgeon's prerogative. It doesn't matter. But
it doesn't make a difference in practice.
So the essence of the story is that you should do a proper R's clearance. If your clearance is less than at least no visible disease in the peritoneal cavity, then only we do a lymphadenectomy. So it's so important to assess properly the upper abdomen completely. Suppose you have done a lymphadenectomy and then you see that you leave a lesion on the undersurface of the diaphragm. So that doesn't work. So you have to do a complete peritoneal dissection, complete it, and then see that it's a R0 and then go ahead with the lymphadenectomy.
So completeness of the surgery is more important than sequence of whatever operative procedures you are performing. I think that's a very important take-home message, especially for people like me who don't do cancer surgery. We are always questioning.
You are too humble, sir.
Thank you, ma'am. So we have Dr. Rakhi Singh with us. Thank you, ma'am, for joining us. And we apologize to the viewers for the delay. Madam was held up with the patient, but she's here with us. And I would request Dr. Latika Agarwal, ma'am, to please introduce our third speaker of the day. Session, can we have the CV slide, please?
So, good evening, everybody. And thank you, Dr. Pratik Tambe, for giving me this opportunity to chair this wonderful session, that is endocrine causes of RPL. So, a very strong subject to be included in a webinar, and a topic that many of us look forward to for being explained and discussed in detail. So, we have done today. Dr. Rakhi is there amongst us to speak on endocrine causes of RPL. And she's the director at Abalone Clinic, Maternity and Fertility and IVF Center, Sector 41, Noida. Diploma, she has done diploma in reproductive medicine and embryology, Germany. And she has done diploma in advanced laparoscopy and hysteroscopy from Germany too. And she held many posts. She is the chairperson of endocrinology committee, FOXY, vice chairperson of UP State SR, and peer reviewer for Journal of Obstetrics and Gynecology of India. And she was the organizing chairperson of North Zone IVA FOXY 2019. She's the president of Noida Society 2013-15. Registrar of UP State Ispat. Let me speak, such a wonderful CV. And she has many awards and achievements to her credit. She was invited faculty for 300 national international conferences. Wow. So this is about Rakhi. And please, screen is yours, Rakhi.
Thank you, Latika, for wonderful introduction. And at the outset, I would like to thank AMOG's team, Dr. Nandita and Pratik Tambe for helping me. And thus RPL being a topic which is of a bigger concern for all of us. And I'm going to talk on that today. There are various causes of RPL. We are going to mainly focus on endocrinal causes. And the patients of RPL have they are very anxious as they want their little one in their arms all the time. And it is very difficult for them to conceive and then continue the pregnancy. And they are very scared of it. I would like to start with a quote that the human mind treats a new idea the same way the body treats a strange protein. It rejects it. It is by Sir Peter. And just a brushing up of redefining and to reclassify RPL nowadays. It is either the 3 consecutive losses what we need to see or 2 or more failed clinical pregnancies what we see. And if the patient is of more than 35 years of age, investigate thoroughly this patient after first miscarriage only, and mostly occurs within 12 weeks of conception that needs to be addressed. And unexplained RPL normally occurs in around 50% of the cases. That needs to be kept in our mind. Ideally, this pre-implantation losses are also there, which would be accounting to less than 4 weeks of pregnancy. And peri-implantation failures also are there, which needs to be kept in our mind. And post-implantation are the secondary losses, what we call them, is there. Coming down to the primary recurrent pregnancy loss is the couple which has never conceived once also. The secondary RPL refers to those who have had repeated losses following a successful pregnancy. Clinical pregnancy loss, ideally, it could be the pre-embryonic loss, which would be less than 5 weeks of gestation, just when the embryo, the yolk sac is also not very well seen or it is trying to get developed. Pre-embryonic, less than 8 weeks is where the embryonic sac has developed, the fetal pole has come down. The fetal losses would be after 8 weeks what we address in the clinical scenario. There are various causes of RPL. Basically, the causes which we are concerned and we are looking of today is the endocrine factors, and which account to around 17 to 20% of the total losses in the RPL. There are various important points which need to be elicited. In the history and the examination, the careful examination and the history needs to be taken. A clarity on the documentation of needs to be done with the recurrent pregnancy losses, whether it was a chemical pregnancy or the early loss, what duration of the pregnancy the loss was there, and whether it was in the first trimester or the second trimester, or whether it was the stillbirths. The patients do get confused among all of these scenarios. So we need to understand that, and also need to check all the papers if the patient is getting all of them, whether it was a full-term birth or any premature births, if the patient has already had any malformed fetuses, any term of the pregnancy at that time of the abortions when it has got, or location of the fetal heart rate was done or not, whether it was documented or not, whether the yolk sac is seen or not, or the fetal pole was also seen or not. All these factors would help us in understanding and coming down to the conclusion what type of RPL the patient is landing up into. There are various environmental and lifestyle factors which do affect our endocrine factors also to a greater extent. So that also needs to be taken into account. That is smoking, whether the patient is smoking or not, whether even if it is a lower socioeconomic strata, she can be having a BD smoking, or it would be the cigarettes with the high affluent societies. That cannot be removed. That needs to be taken into account. And if the patient is into any of the furnaces working with it, or it is an anesthetic or toxic chemicals which she's exposed to, and whether what is the lifestyle of that patient, whether she's obese or if she's very thin and lean, the number of the caffeine intakes, the alcohol consumptions, any drug medication she's taking regularly, or any use of NSAIDs which she's been doing regularly. Various chromosomal anomalies have to taken into account and kept in the mind. if the patient's age is more. After 35 years, as the chromosomal anomalies increase, that needs to be kept into mind before landing up into the endocrinal causes of RPL. The various anatomical causes also needs to be understood. All the women with one or more second trimester miscarriages should have a pelvic ultrasound to assess the uterine anatomy when the uterus is empty without any of the fetuses being there. And if required, the hysteroscopy or the laparoscopy needs to be done. Today, we're going to deal about the endocrine causes. We are going to mainly talk on the polycystic ovaries, which account to around 20 to 40% of the endocrine causes for the RPL. Luteal phase defect account to around 23 to 60% of the cases, and hyperprolactinemia, autoimmune thyroiditis. These are the various causes in endocrinal causes for RPL. PCOS, the mechanism by which LH exerts an adverse effect is not clear. Raised follicular phase LH may cause premature resumption of meiosis, production of physiologically aged oocytes. LH causes endometrial defect. Suboptimal implantation is seen in these cases. LH may cause increased secretion of androgen from the ovary. There was a study on recurrent pregnancy loss in PCOS with hyperhomocystinemia and the insulin resistance. RPL is found in around 1.5% of the couples with desiring pregnancy, and a plethora of factors which have been addressed are associated with pathophysiology of RPL in PCOS. The common metabolic derailment of the syndrome, like obesity and insulin resistance, have been implicated as individual risk factors for RPL. Recent evidences suggest another metabolic component, that hyperhomocystinemia, to be a frequent association in subjects with PCOS for the causing of RPL. Diabetes and RPL do have an association. Diabetic women with good metabolic controls are probably no more likely to miscarry than non-diabetic women. Diabetic women with raised glycosylated hemoglobin concentration in first trimester are at increased risk. Diabetic patients should be euglycemic before attempting for the pregnancy. Hyperprolactinemia or the luteal phase is shortened in these patients. Prolactin interferes in normal activity of developing placenta. Prolactin levels are often measured for assessment of ovulatory function, and they are not possibly associated with PCOS. And luteal phase deficiency and stress and obesity, these all can lead to part of the recurrent pregnancy losses. And apart from that, ideally the hyperprolactinemia is not to be measured during pregnancy. Ideally, the correction needs to be done before the conception itself. Luteal phase defect in relation to RPL, it is common in RPL. Inappropriate corpus luteal function can lead to the inappropriate production of the progesterone, leading to inadequate endometrial preparation. Thereafter, the implantation is hampered, thus the pregnancy to be sticking around and continuation of the pregnancy is difficult because the corpus luteum is not well formed and it doesn't secrete that much amount of the progesterone. And progesterone, as it has the immunomodulatory effect, an increase in the production of progesterone reduces the blocking factors, which leads to suppression of the natural killer cell activity. And this suppressive effect favors the implantation and progresses for the early development of the fetus. Ideally, the supporting the luteal phase, let's see how, what, when, and why, and how much we need to support our luteal phase for these patients. Numerous studies have confirmed that ovarian stimulation with controlled ovarian hyperstimulation cycles is associated with luteal phase defects if they are not supported to that extent when the gonadotrophins are given in those cycles. Luteal phase defect presents in the administration of the drug to support the process of implantation. Luteal phase supplementation is crucial between the disappearance of exogenous HCG administered for final oocyte maturation and the rise of endogenous HCG during the early implantation. Ideally, when to start and when to stop luteal phase support is most important, and the protocols advocate to the use of luteal phase support throughout the first trimester of the pregnancy. There is no difference in the CPR or the OPR or spontaneous abortion rate between stopping and continuing of the luteal support after positive pregnancy test. Luteal phase support till positive pregnancy test needs to be given according to Jacob and all in 2003. Conclusion ideally is optimal length of treatment remains unsolved at present, and further trials are needed before we clearly recommend. And most of the clinics in India, they give the luteal phase support because as it is with these RPL patients, they are wanting the pregnancy in hand. And if we are just supporting the pregnancy according to the science and data is till the viability of the fetus, which is the heartbeat once it comes, then the patient, if the patient lands up in the missed abortion, then we are nowhere and then we have to answer. So I prefer personally to give it up till 12 weeks till the placenta takes over. When to stop the luteal phase? At the time of positive pregnancy test, ideally they tell it, and then the Constable and all, they had told at 8 weeks, and Check and all in 1991 had reported that we need to stop it at 10 to 12 weeks. The Cochrane review in 2012 has shown that the suggestion of significance suggests a significant effect in favor of the progesterone, which needs to be supported till good 12 weeks of pregnancy. And then again, the Cochrane review, here it has shown that progesterone versus placebo or no treatment, the outcome of the pregnancy was good if it was supported, and it was significantly supporting the progesterone, which needs to be supplemented. To summarize, progesterone in use for the RPL, progesterone support starts after the positive pregnancy test, and there is no benefit according to them, but luteal phase support may be of little benefit according to the fertility sterility in 2017 by Stepsons. Coming to the key important points, what we need to understand till now, what we have learned is luteal phase insufficiency testing is not required and not recommended in these patients with RPL. Androgen testing is not recommended in women with RPL. And LH testing is not routinely recommended in women with RPL according to Prakash and all in 2006. Measurement of high homocysteine plasma levels is not routinely recommended in women with RPL according to Zamit and all in 2008. Assessment of polycystic ovarian syndrome and the fasting insulin and fasting glucose is not recommended in women with RPL to improve next pregnancy prognosis. But we need to check the fasting glucose and level or the OGTT in all these PCOS patients, and to correct it, as it is insulin resistance would be there in these patients. Ovarian reserve testing is not routinely recommended in women with RPL. Prolactin testing is not recommended in women with RPL in absence of clinical symptoms of hyperprolactinemia. That is, if the patient is not pregnant, then we need to check it during the pregnancy. We are not checking it. And coming down to the other big battery, which is the thyroid and RPL relationship. Hypothyroidism, ideally we need to check and keep the target level of thyroid up to 2.5 in the first trimester and up to 3 in the second and the third trimester. That is the cutoff values which we need to take into account and move ahead. Hyperthyroidism rarely or independently is a cause of RPL, and subclinical, or if it is hyperthyroidism is there, then there is no requirement for any treatment. Overt, we need to target free T4 levels, and mildly upper range, if it is there, then we need to treat it. hypothyroidism, which can impair the infant's neurocognitive development. There are also increased risk for premature births, low birth weight, and miscarriages. Overt hypothyroidism must be treated. If TSH is high and T4 is normal, the diagnosis is subclinical hypothyroidism. In this case, the next step is to check for antithyroid peroxidase antibodies. Women who are antibody positive should be treated. Thyroid autoantibodies and RPL. Prevalence in females is 5 to 10%. Association, major studies show association. Few large studies show no association, and it is little controversial. Some studies show correlation with the titer and unlikely to be one of the cause, but ideally we need to correct the thyroid level before conception only. And once the patient is conceived, then the thyroid autoantibodies serve as a peripheral marker for abnormal T cell function and not necessarily be the abnormal pathogenic causes. Thyroid screening and thyroid peroxidase antibodies is recommended in women with RPL, abnormal thyroid stimulation, or the hormone, and thyroid peroxidase antibody levels should be followed up with thyroxine T4 testing in women with RPL. And we need to maintain the level of TSH by checking it regularly every 3 months. Once it is come within the range of 2.5 in the first trimester and 3 if it hits down below 3 in the second and third trimester, regular follow-up and checking of the thyroid level needs to be done. How do we do the follow-up for these patients? Euthyroid level has to be maintained with less than 2.5, and the role of steroids, IVIG, needs to be given if required. And selenium needs to be checked or not. That is controversial at times. TSH every 4 weeks in the first 20 weeks and at least once between 26 and 32 weeks of gestation. Coming down to the unexplained RPL, tender loving care is most important, which needs to be done. Even after 3 miscarriages, the chances of success without the treatment is approximately 60% in the patients where it is unexplained. And if suppose antiphospholipid antibodies or thrombophilia is present, then it is the success rate is little lower, but otherwise most of the patients, they do conceive. And even after 3 miscarriages, the chance of success without the treatment is approximately 60% for these. The main points to remember is the basic diagnostic workup which needs to be done. Understanding of possible reasons for miscarriage needs to be understood. Extensive diagnostic workup or detailed history needs to be taken. Half of the work is done, and for all the successful treatment. Future trends would be accurate diagnosis, stop looking for panaceas, first determine if embryonic or the maternal causes of RPL. From evidence-based to tailor-made, we need to go ahead. Points which we need to understand is the cause of the RPL, whether it is, what is the prognosis, what is the treatment, investigations. These are all the points which need to be answered to the patient, and we also need to understand that. Immunopotentiation has to be done. Anticoagulants can be given. Correction of uterine anomalies if anomalies are there. Then hormone supplementation needs to be done, which is important in all the endocrine factors. And most of this hormonal correction can be done before the patient conceives, and do not wait for another second miscarriage to happen to label the patient as an RPL. And if the patient is undergoing an ART cycle, please understand the ART cycle, what she's done. And if it is an IVF or an ICSI, then she needs to be supported, what type of cycle she has taken. Accordingly, the things need to be addressed. Remember, the woman who have had at least one born live infant has a good prognosis. Women who have not had at least one live born infant with 2 or more fetal losses, recurrence risk for the next pregnancy is around 40 to 45%. Thank you for all your patient hearing.
So thank you so much, Rakhi, Dr. Rakhi, for a wonderful presentation. Everyone knows that Dr. Rakhi is a wonderful orator and she knows her subject well. And she has again proved it today. And very crisp and immaculate presentation. So each and every aspect she has covered so beautifully. And I am sure all will benefit in their day-to-day practice from today's session. Thank you so much, Dr. Rakhi, for this wonderful and nice presentation. I want to ask you one question, Dr. Rakhi.
Yeah.
Usually we do APLA test in recurrent pregnancy loss, and many a times we see it is not positive, but still we give low molecular weight heparin. So we do it right or wrong? According to you, what do you do?
Ideally, if the APLA test is negative, we are not supposed to give it. We cannot stand in the court of law if we are giving it.
But I think many of us are doing this and
yes,
getting the results also.
It is ideally not to be done until unless, because if suppose that patient goes and lands up with a paper in the court of law, we don't have any answers for that. Why have we given? There has to be a reason for putting the patient. If suppose the patient lands up with a heavy bleeding, after putting up for the heparin, we don't have the answers for that. And the patient loses that pregnancy, we don't have the answers for that.
Right. Usually we don't have the bleeding with, in my practice, I don't have such incidences. I don't have bleeding, but the patients don't have bleeding with low molecular weight heparin. Usually they don't land up, but we never know. I had one patient whom it was not an APLA patient. For an IVF only I have taken up. She just with 2 doses, her BTCT and APTT PT, everything was within normal limit. I had put her up on heparin, but she had a good amount of bleeding. Okay.
So we never know which patient can land in which form.
So a note can be written on the paper of the patient that this injection is given empirically and this is...
let the patient write it down that the patient is ready to take that. But then also it will not stand in the court of law because you are a doctor. How can the patient decide and take the injection on their own? We cannot stand in the court of law with that answer.
Okay. Thank you so much, Doctor.
One more option is to start preconceptional aspirin 150.
Yes.
That is better option.
We do in our practice. We do that. Yeah. That is.
Thank you very much, Dr. Latika Agarwal ma'am and Dr. Rakhi Singh for a wonderful talk. Thank you so much despite your busy schedule squeezing us in. We had 3 excellent talks from 3 eminent faculty. We have nearly 500 people logged in from all across the country. A lot of congratulatory messages from the audience, including one particular message which I would like to convey. This is for Dr. Bhagyalakshmi and this is from Dr. Seema Saxena from New Delhi. And she says, perfect explanation. It shows her vast command on surgery. It's a huge topic and time is unfortunately too less. So that's something which echoes all of our feelings and sentiments. Maybe we can have Dr. Bhagyalakshmi back again on another day and we'll invite her again to address different types of humors and we all would welcome her again on this AMOX platform. I'm sure all of us will learn a lot from her. Dr. Sagar sir, as the zonal coordinator and the senior representative from AMOX, your remarks. I don't see any other relevant questions from the audience so far. So some concluding remarks from you would be most welcome.
Thank you, Pratik. It was a wonderful webinar and we had 3 very expert speakers and it was very dedicated talks on the different fields like oncology, recurrent pregnancy loss and fibroids. So it was all in all a wonderful webinar covering different aspects of OBGYN practice. Dr. Bhagyalakshmi gave an excellent talk about recent advances in management of CA ovary and the videos and the presentation was excellent and there was a very deep insights into the oncology for budding gynecologists and also for well-established old consultants like me, how to approach the patients of CA ovary and how they can be managed further and what are the possibilities of and what are the newer treatments like HIPEC and intraperitoneal chemotherapy like that. Then there was a talk on non-hormonal treatment of fibroids. It was also a very good talk regarding the how better we can understand the pathophysiology of fibroids and how we can handle the patients of fibroid if we don't want to operate them, how to tackle them with medical line of treatment. And of course, the concluding lecture of Dr. Rakhi Singh was an excellent presentation on RPL, especially the endocrinal causes. She has very well explained the need of progestational support and different evidence-based therapeutic modalities and how to tackle the different endocrinological problems associated with RPL. So all in all, it was an excellent webinar, and I thank all my co-chairpersons and all the AMOG's team for having this wonderful webinar, and of course the special thanks to Dr. Pratik for this wonderful webinar. Thank you.
So if anybody has anything else to add, please feel free.
I have one question for Dr. Tambe. That is,
Yes, sir.
So whether to prefer non-hormonal treatment for fibroids or to prefer mifepristone. Now ulipristal is mostly we are not using because of liver damage problems. So what we preferred, whether to prefer non-hormonal or to prefer mifepristone?
So mifepristone is one of the established drugs, and there are good evidence.
I think the link is lost.
Sir will be joining in shortly.
Can you hear me? Yeah, I think there's some glitches in the internet. As I was saying, sir, mifepristone is widely available and it's easily accessible. Many patients like it. There are less side effects or adverse drug reactions with mifepristone. It's a well-established drug. Even in Indian population, there are good studies in Indian population as well. But now we have newer modalities which are available. We still have less evidence for these particular options in Indian patients. Until we actually try them out, use them, see the side effect profile, see the patient compliance and acceptance, we won't really know how effective they are. But the small, limited numbers that we have is being shown that right across the country, the So, of course, the jury is still out. We need more evidence-based publications. We need more randomized trials and multicentric trials before we can make a wider recommendation. Today's talk is just for creating awareness that we have options available, especially during the height of the pandemic when offering patients surgery was not easy. Elective surgeries could not be performed in the lockdown era. So that is especially a time when we need more medical options that can be offered to patients, especially if they have less side effects and compliance is good. That was the perspective that we had.
Dr. Pratik, I want to say,
yes, ma'am.
When I sent this flyer to Dr. Nutan Jain, so she sent me few lines. I want to read. She said, fibroids medical management has been the worst disaster of gynecology. Ask the surgeons who struggle every day with these medically treated myomas. So anyone want to comment on this?
Yeah.
So being an endoscopic surgeon myself, I can say that if you use something like your sandwich therapy, which we used to practice once upon a time, surgery becomes technically much more difficult. That is a fact. But then the other options which we now have, those are much more readily acceptable and patients are quite compliant with those particular drugs. We still don't know what the effect of these newer formulations is going to be in those patients who we are going to operate tomorrow. That's something which we still need more data and we need more publications before we can make a comment.
It is more relevant with GNRH analogs and like
absolutely, sir. Absolutely, sir. So I think I'll present the formal vote of thanks at the end of today's wonderful program. I'd like to express my gratitude to the AMOG's office bearers, our esteemed President, Dr. Nandita Palchetkar, who has just today been awarded the Fellowship of the Royal College of OBGYN in London at a wonderful ceremony. Thank you so much, ma'am, for your blessings and your guidance always. I'd like to also express my gratitude to the Secretary of AMOG's, Dr. Arun Nayak, to the ICOG Chairperson, Dr. Uday Thanawala, the Secretary of ICOG, Dr. Ashok Kumar, our three esteemed chairpersons, Dr. Sagar Kataria, Zonal Coordinator of AMOG's, Dr. Shashmita Das, past President of Karimnagar, Dr. Latika Agarwal, who is the Secretary of PSR, and three wonderful talks from Dr. Bhagyalakshmi Nayak, Chair for the Oncology Committee of FOXI, Dr. Rekha Thote, the Secretary of Thane OBGYN Society, and a dear friend, Dr. Rakhi Singh, Chairperson for the Endocrinology Committee. Thank you so much for being here with us. My gratitude also to our academic partners, Acumentis Viviana, the Science Integra backend team led by Subbu, Session and Shimon. Thank you so much, Session, for being here today despite your poor health. We hope you recover soon, and we'll see all of you in the audience who have joined us in large numbers at the next event in a few days from now. Until then, goodbye, God bless, and take care. Bye for now.